Good afternoon, everyone. My name is Maya Luria with TMC for Seniors. And today we are going to be wrapping up our Women's Health Month with gynecologic cancers, what every woman should know. I have Dr. Candice Lewis here with me. She is with our TMC Health Cancer Center. How are you today, Dr. Lewis?
I'm great.
Great. So you do have an online audience that's watching at home, and along with an in-person audience today. I'm going to go ahead and put up your PowerPoint for you so that you can start your presentation. If you're watching from home, please feel free to enter any questions into the chat, and I will ask Dr. Lewis afterwards. It's all yours, Dr. Lewis.
Okay, thanks. All right, so I'm a GYN oncologist. I treat cancers of the female pelvic organs. And so my goal today is to give you some information about those cancers. But my primary goal is to give you the knowledge to be able to recognize the symptoms of these cancers. You know, what we know is that cancers that are diagnosed early have the best outcomes. So early diagnosis, best chance for cure, best chance for survival. And by knowing the symptoms, you will be able to empower yourself to be able to seek care early. So, this side. Okay, thank you. Okay. So a lot of the information that I'm going to talk about today and what you're going to see on the slides comes from the Foundation for Women's Cancer's website. And so their website is a great source of information. If you want more information after the talk today, I would encourage you to look up their website. They are focused on education and awareness, realizing that if a woman knows the symptoms, they will be able to be more proactive in their health and be able to reduce their risk of dying from these cancers. So what is cancer? Cancer refers to a disease process that is characterized by cells that have uncontrolled growth. And so those cells then, if they continue to grow, can then spread to other parts of the body or metastasize. So gynecologic cancers are cancers that start from the pelvic organs. Every year, about 110,000 women in the US are diagnosed with a gynecologic cancer. So the cancers that we're going to talk about today are cancers that originate from the uterus, from the tubes and ovaries, from the cervix, the vagina, and the vulva. So this is just a more detailed picture of the pelvic organs. And the cancer that we're going to start with today is cervical cancer. So when you go into the office and we put a speculum in your vagina, you put the speculum up through the vagina and we open it, and the view of your cervix that we get looks like this. The cervix is a round structure. It is the opening of the uterus. The internal opening, or the os, is what typically dilates when a child is born. So we look at the cervix, and this is what we typically see. So the cervix normally has two cells. The cells on the outside of the cervix that we see when we look in are called squamous cells. The cells that are inside the canal of the cervix are glandular cells. And so the cancers that develop from the cervix can be either a squamous cell carcinoma or an adenocarcinoma, depending on where they originate. Cervical cancer is the only gynecologic cancer that can be prevented by doing regular screening and also by appropriate vaccination. So the cervix, again, this is kind of a view of a normal cervix. It has kind of a shiny appearance, and it's very smooth when we look at it. When you look at this picture, you see what's called the squamocolumnar junction here. The squamocolumnar junction is the junction where those squamous cells meet the glandular cells of the endocervical canal. That squamous columnar junction moves over time. So over the course of a woman's lifetime, what we see is that the glandular cells normally occupy more of the outside of the cervix. And through a process called metaplasia, those glandular cells are replaced by squamous cells. So the squamous columnar junction will eventually migrate in towards the opening. And then that distance between the original squamous columnar junction and the new squamous columnar junction is called the transformation zone. And the reason that that's important is that that is where most cervical cancers develop. So this is a slide of what a biopsy of the cervix might look like. So in a normal biopsy, in a biopsy of a normal cervix, this is a picture of the epithelium or the skin layer of the cervix. And so normally there's a basement membrane that's lined by basal cells, and then there's maturation of the squamous cells. In precancerous conditions, we categorize them based on their severity. With low-grade lesions, there are abnormal cells that occupy the lower third of the epithelium. With moderate precancer, they occupy approximately 2/3. And then with severe precancer, those abnormal cells can extend the full thickness of the epithelium. To progress to invasive cancer, what happens is that those cells then start to invade that basement membrane and into the structures beneath the epithelium. And so this is another depiction of kind of the progression of those changes. Up here in this quadrant, we see a fairly normal appearing cervix. This is what we might see if someone has a low-grade precancerous condition. And these changes are typically only visible with a microscope. But what we can see when we look with the microscope are the beginning changes of abnormal vasculature within the epithelium of the cervix. That abnormal vasculature becomes more severe with a high-grade lesion, and then with an cancer, it becomes even more severe when we start seeing vessels that look like corkscrews, irregularity of the surface of the cervix, and we can start to see ulceration or growth of tissue above the surface of the cervix. So what are the risk factors for cervical cancer? Well, the main risk factor is the HPV virus. So almost all cervical cancer is caused by the human papillomavirus. The human papillomavirus is a sexually transmitted disease. And so what most patients don't know is that it's very common, and that the estimates are that approximately 80% of people who are sexually active will have contracted the virus by the age of 50. So it's a very common virus to have. The progression for having an infection to going on and developing cervical cancer requires that that infection be persistent. So what normally happens is that most patients who are exposed to the virus, their body's immune system controls it, puts it into a dormant phase where it's no longer replicating, and then it typically doesn't cause any problems. But in patients where their immune system has difficulty controlling it, it becomes a persistent active infection, and then that can go on then to lead to cervical cancer. Cervical cancer usually affects women between the ages of 30 and 50, but both younger and older women are at risk. One of the things that's important, again, is your immune system, and so things that weaken the immune system also increase your risk for developing this cancer. So smoking is a big one. We know that smoking affects the immune system and its ability to control the virus. So it is a risk factor for developing this cancer. Other things that can affect your immune system would include diseases like HIV, having a history of a transplant where you're required to take immunosuppressive medications, taking other medications like steroids or immunosuppressants for diseases like lupus or rheumatoid arthritis. Those patients have a higher risk of developing precancer and cancer. So what are the symptoms? Symptoms for cervical cancer typically are present once the cancer reaches a certain size. So most cervical cancers, when they're early, actually have no symptoms. But symptoms that we can see if someone has developed cervical cancer would be vaginal discharge, abnormal vaginal bleeding, vaginal odor, and pelvic pain. So again, with this presentation today, this is what I want you to remember. I want you to remember these symptoms so that you know that if you develop these symptoms, you need to seek medical care. So again, most women with early stage cancer actually have no symptoms. And so the routine exams with a pap smear and HPV testing is the key to preventing this cancer and for diagnosing it. So pap smears are typically recommended to be performed every 3 to 5 years with HPV testing, and that continues until the age of 65. Now, a lot of women are told once they reach 65, they no longer need a pap smear. Well, for some patients, that's true, but there are certain criteria that make you eligible for continuing to have pap smears. And so those criteria would be that if you've ever been treated for precancer, if you've ever had a LEEP procedure, a cold knife cone procedure, freezing of your cervix, and that has occurred within the previous 25 years, then you need to keep having pap smears. Also, to be a candidate to stop having pap smears at the age of 65, you have to have had at least 2 to 3 normal evaluations within the last 10 years. So if you don't meet those criteria, you need to continue having pap smears. And so that's something that I think some women get their pap smears through their primary care provider. Their primary care provider might not be as knowledgeable of those guidelines. And so it's something that you should be aware of, that if you have any of those risk factors, you need to continue having pap smears after the age of 65. So what happens when you have an abnormal pap smear? Well, the first step is typically to have something that's called a colposcopic exam. A colposcopic exam is an exam where we use a microscope to inspect the cervix. We typically apply a dilute vinegar solution to the cervix, and that vinegar solution helps us to see abnormal cells. So if during that evaluation we were to find an abnormality, then we would move on to perform a biopsy. And then if the biopsy returns with a precancerous condition, we often can treat that by removing just a portion of the cervix, and that can prevent that precancer from then going on and becoming cancer. If the biopsy then were to show a cervical cancer, then we continue on with the workup. And so with each cancer, every cancer is staged differently. Each cancer has its own criteria for staging, and staging can be either clinical or surgical. Cervical cancer is a disease that we stage clinically, and what that means is that because a lot of patients end up not having surgery, we do the staging through other tests such as imaging and other procedures. So patients may have a CT, an MRI, a PET CT. We may perform a cystoscopy where we put a camera in the bladder to see if there's any invasion of the bladder, or a proctoscopy where we look in the rectum to see if there's any evidence of invasion. And then that determines the initial stage of the cancer, and that determines how we might treat the cancer. So cervical cancer, the stages, there are 4 stages. The first stage is where this cancer is found only in the cervix. The stage 1 is actually subdivided, and I did include those here, into 4 different categories based on whether the disease is microscopic or whether it's visible to the naked eye. Most stage 1 cancers can be treated with either surgery or radiation. And we determine that based on the medical conditions of the patients, whether they're suitable for surgery, and anything else that might affect their ability to tolerate the treatment. Stage 2 cancers is where the cancer has then spread to the adjacent structures. So the most common thing that these cervical cancers do is they may spread to the adjacent upper vagina, or they may spread to what's called the perimetrium. The perimetrium is the tissue immediately adjacent to the cervix. When it does spread to the adjacent perimetrium, the key for it to be stage 2 is that it has not spread all the way to the sides of the pelvis. If it has spread to the sides of the pelvis, then it's considered stage 3. And stage 3 is also if it spreads down to the lower vagina. And then stage 4 cancer is where the cancer has spread to other parts of the body. It may spread into the upper abdomen, it may spread to the lungs, it can spread to the lymph nodes above the clavicles. And so typically anything above stage 1 is treated with radiation and chemotherapy, or chemotherapy alone if it's advanced to stage 4. So who treats you? Well, if you are diagnosed with a gynecologic cancer, typically you're going to be referred to someone like me, a gynecologic oncologist, who will direct your care. And then, if appropriate, we may refer you to a radiation oncologist who would be in charge of the radiation. We typically perform the surgery and the chemotherapy. The radiation oncologist performs the radiation for these cancers. You will also have a chemotherapy nurse who you will get to know very well. And social workers may be involved to help guide you through the process. So again, the treatment. Treatment can consist of either surgery or chemoradiation. A lot of patients, come in and they say, I just want it taken out. Well, that's not always feasible, especially with the more advanced disease. We can't remove them safely without increasing the risk of side effects, and we actually can reduce the chance of survival by doing that. So for early stage cancers, we treat them with surgery. At more advanced stage cancers, we treat them with chemoradiation. And the surgery can consist of different procedures, again, depending on each patient's age, their comorbidities, or their other medical conditions. If someone is young and still is trying to have children, we may do something called a conization, where we're only taking a small portion of their cervix so that they can retain their fertility. For someone who's young, but the cancer is a little bit more advanced, we might do what's called a radical trachelectomy, which is again taking the cervix, but then we also take the upper vagina and the perimetrium with it. Other patients might qualify for a simple hysterectomy, and then bigger cancers we would typically treat with what's called a radical hysterectomy. The radical hysterectomy means we're taking the uterus, the cervix, at least the upper 2 centimeters of the vagina, and that perimetrial tissue. And then most commonly in that situation, we're also going to be sampling the lymph nodes and the pelvis. Removal of the tubes and ovaries does not always have to be performed with this cancer. Cervical cancer does not commonly spread to those organs. So again, the decision to remove them would be based on the patient's age and desire for having them removed. If someone's cancer is more advanced, then we typically would refer them to the radiation oncologist for chemoradiation. There's different forms of radiation. Most of the time, there's a combination of treatments where the initial treatment is given as external radiation. That's similar to having an X-ray. You lay on a table, a beam of energy is directed to your pelvis. That typically is done daily for over a course of 5 to 6 weeks, and is usually combined with once a week chemotherapy. And then at the end of that 5 to 6 week period, the patient would then progress on to receive internal radiation, where a device is put up in the vagina adjacent to the cervix, and it delivers a high dose of radiation to the cervix. So risk reduction, what can you do to reduce your risk? Well, the main thing you can do, like I said, this is the only gynecologic cancer that is potentially preventable. And so if you get your Pap tests or HPV tests on a regular basis, you can reduce your risk. It is important that you also, once you have those tests, make sure you get your results. Make sure that you understand your results, and you set up a follow-up plan with your physician and put that in your calendar so that you don't forget. The HPV vaccine is something that you all don't qualify for, but it is something that we are now recommending for preteens. The HPV vaccine has been found to be very effective in preventing both precancer and cancer. So it's typically given to preteens who are in the 11 to 12-year-old range. That's when it tends to work best. It has the best chance of reducing their risk of developing precancer or cancer. It can be given as early as age 9 and up to age 25 are the typical recommendations. It also can be given to older patients up to age 45, depending on their circumstances. The HPV vaccine, of course, is beneficial for females, but it is also beneficial for males. And the main risk reduction we see with males is the reduction in risk of anal cancers that can be HPV related, and then oropharyngeal cancers. And so we recommend both boys and girls get vaccinated. So again, early detection improves survival. So remember these symptoms. If you have abnormal bleeding, abnormal discharge or odor, pelvic pain, those are reasons to seek care. So the next cancer we're going to talk about is ovarian cancer. And I'm going to, in the presentation, just refer to ovarian cancer. But ovarian cancer encompasses different sites of disease which act the same. So ovarian cancer, fallopian tube cancer, and a cancer that's called primary peritoneal cancer, which is a cancer that develops from the peritoneum or the lining of the abdomen, are all histologically identical, meaning that if we look at them under the microscope, they look the same and they act the same. So we treat them the same. So this is just a prettier picture of a pelvis with a not so pretty ovary. So a normal ovary in a postmenopausal woman is very small. So usually maybe about the size of a walnut or a little bit bigger. Often when postmenopausal women get an ultrasound, a pelvic ultrasound, they often can't even see the ovaries because of how small they are. So with an early ovarian cancer, what we would typically see is that the ovary would enlarge, and then the surface, which is normally smooth and kind of pearly white, would become irregular and can have nodules on the surface. Ovarian cancer is the 7th most common cancer in women, and it usually starts from the cells that are on the surface of the ovary, which are called epithelial cells. Of all ovarian cancers, about 85 to 90% are epithelial in origin, and they start from the surface of the ovary, but as they grow and metastasize, they can implant other places in the abdomen. So the types of ovarian cancer are epithelial, which is what we're going to talk about today because it's the most common. But there are also germ cell cancers of the ovary and stromal cancers of the ovary, which originate from the tissues that are on the inside of the ovary. So epithelial ovarian cancer, again, represents about 85 to 90% of all ovarian cancers. It is the 5th leading cause of all cancer deaths in women in the United States. And it causes more deaths than any other gynecologic cancer. And why does that happen? Well, it's because that unfortunately 2/3 of patients who are diagnosed with ovarian cancer come in where it's already stage 3. So unlike cervical cancer, we don't have a screening test for ovarian cancer. And so again, knowing the symptoms can help you to potentially be diagnosed at an earlier stage. Ovarian cancers may be part of a hereditary cancer syndrome where a genetic mutation that's being passed on in a family can result in these cancers. So symptoms that you need to be aware of. So unfortunately, the symptoms with ovarian cancer, especially when it's early, are very vague. Patients might present with bloating. They might present with pelvic or abdominal pain, with urinary symptoms such as urgency or frequency, and then difficulty eating. They eat and then they feel full very fast and can't eat a lot. So when should you seek medical care? Those symptoms sound very common, don't they? So, obviously those symptoms can be caused by a lot of other things. They can be caused by things that are not cancer related. But we typically say that, if those symptoms are persistent, where they've been present daily for more than a few weeks, that's a reason to go in and get checked out. If those symptoms are progressive, they're progressively getting worse over time, or if it's just a change from your normal, those are reasons to seek medical care. Other symptoms that we might see with ovarian cancer would include fatigue, indigestion or heartburn, back pain, pain with intercourse, changes in your bowel movements, and menstrual irregularities. So what happens when you go in with those symptoms? Well, what should happen is you should have a full physical exam, and that includes a pelvic exam. And so if your primary care physician doesn't perform pelvic exams, you need to be seen by your gynecologist or be referred to a gynecologist for a pelvic exam. And then from there, typically other tests are also ordered, including a pelvic ultrasound and potentially blood work, which would include what are called tumor markers. Tumor markers are blood tests that are antigens that are produced on the surface of cells. They can be useful in helping us make a decision about whether something that we're seeing on an ultrasound is concerning or not. They are not diagnostic, so the CA-125 level, which is the common test that we perform with this cancer, it is very nonspecific. It can be elevated when you don't have cancer, and it can be normal when you do have cancer. So we always have to take it with a grain of salt. But it's just another piece of information that we can use when we're trying to determine what's going on. Patients may also have a CT or an MRI, and then depending on the findings, sometimes a biopsy is performed. That biopsy typically wouldn't be of the ovary. We try not to biopsy the ovary if that's the only thing that looks abnormal. But if we were to see other things in the abdomen that look abnormal, we may perform a biopsy of those structures to see if there's evidence of cancer. So if ovarian cancer is diagnosed, again, it's put into 4 different stages. Stage 1 refers to cancer that is still confined to the ovary or the fallopian tube. Stage 2 refers to cancer that has spread to the adjacent pelvic organs. So if it started from the ovary, if it has spread to the tube or to the uterus, that would be considered stage 2. Stage 3 disease, and again, this is where most patients are diagnosed. Stage 3 disease means that the disease has spread from the pelvis into the upper abdomen. And then stage 4 disease is again distant spread. So distant spread can mean that it has spread to the lungs. It can spread to the cavity around the lungs. Also, if it involves the tissue of the inside tissue of the liver or the spleen, that would be considered stage 4. So treatment for ovarian cancers, again, depends on stage and the general medical condition of the patient. The standard treatment would be to perform what's called a debulking procedure as the primary treatment, and that debulking procedure refers to when we take the patient to the operating room, and our goal is to try to remove as much of that cancer as possible. And then after the surgery, if that is confirmed, whether they have an advanced disease, that surgery is then followed by chemotherapy. And the chemotherapy is typically administered through an IV. It usually takes roughly about 4 to 4.5 months to complete. And most patients with that combination will achieve a remission by the end of the treatment. Some patients, when we do their initial evaluation, we may find that there is too much cancer, that we don't think that doing surgery makes sense initially. Our goal when we go in to do the surgery is to remove as much of the cancer as we can, all of the cancer if we can. And sometimes when we look at someone's imaging, we know that the likelihood of us being able to do that is very low. And so in those patients, we may choose to start with chemotherapy, and that's called neoadjuvant chemotherapy. And in that situation, then we would usually treat the patient with 3 to 4 rounds of chemotherapy. We would re-image them, and if they've had an appropriate response to that treatment, they would then be taken to surgery for an interval debulking, and then that surgery would again be followed by a couple more rounds of chemotherapy. And again, most patients in that situation then get to remission. And so cytoreductive surgery is the surgery that we do for this cancer, and it can be a very big procedure. So most of these surgeries are performed through a big up and down open incision on the abdomen. And in that surgery, our goal is to remove the uterus, tubes, ovaries, something that's called the omentum, which is a fatty apron that hangs off the colon. That omentum is a very common place where this cancer spreads. We may be removing lymph nodes. The cancer also commonly spreads to other structures like the bowel, sometimes the spleen, sometimes the diaphragm, and we would potentially remove those structures as well if we could safely do so, and it would result in what we call an optimal debulking, where we've removed the majority of the cancer. And then chemotherapy, again, is drugs that are given to kill the cancer cells, and most commonly we do that through an IV. There are other forms of chemotherapy that can be given, such as intraperitoneal chemotherapy or something that's called HIPEC, which is heated intraperitoneal chemotherapy. But the most common way of approaching it is giving it through the IV. The chemotherapy, once it's injected into the vein, travels throughout the bloodstream and it reaches all the tissues that your blood reaches. And then once someone is done with that period of surgery and chemotherapy, they are typically a candidate for what is called maintenance therapy. Maintenance therapy is where we are giving additional medications which will help to keep the patient in remission. So sometimes we give them a drug that's called bevacizumab, which is a targeted therapy that targets blood vessel growth. In other patients, we give what are called PARP inhibitors. PARP inhibitors are very commonly given to patients who have BRCA mutations because they work very well in those patients. And then the maintenance therapy is typically continued for a period of 2 to 3 years as long as the patient is doing well. We know that ovarian cancer is a hereditary problem in about 15 to 20% of cases, meaning that in those cases, there is a genetic mutation that the patient has that has predisposed them to this cancer. And so we now recommend testing all patients who are diagnosed with ovarian cancer. We recommend that they undergo genetic testing. And so what that means is that a blood test, usually a blood test, is performed, which is then analyzed, and they analyze a panel of genes for any mutation. The most common ones are the BRCA mutations, BRCA1 and BRCA2. These genes then increase the risk of developing breast and ovarian cancer and some other cancers, and they can be passed on in the family. So patients who have that mutation can pass that mutation on to both their daughters and their sons. And so once we've diagnosed someone with a mutation, we typically have been seen by a genetic counselor to talk about that mode of transmission and to talk about recommendations for testing of their offspring or other family members and screening for other cancers that they may be at risk for. So risk factors for ovarian cancer, well, this cancer is more common as you age, and it is more common from menopause on. Patients who have a family history of ovarian cancer, fallopian tube cancer, primary peritoneal cancer, or who have a family history of premenopausal breast cancer, or their own personal history of premenopausal breast cancer are at increased risk of developing ovarian cancer. Infertility and not having children is also a risk factor. And we know that pregnancy and the use of birth control pills actually reduces the risk of ovarian cancer. Some people who have a family history of colon and endometrial cancers may have a different genetic mutation called Lynch syndrome. Lynch syndrome also increases the risk of ovarian cancer. And then patients who are of Ashkenazi Jewish heritage also have an increased risk. So, unfortunately, only 15% of these cancers are diagnosed in stage 1, where we think we have a good chance of curing that cancer. 1 in 71 women will develop ovarian cancer in their lifetime. And again, it's the 5th leading cause of cancer death in women in the United States. So don't ignore the symptoms. Again, these symptoms are vague, but if you have these and they don't go away, you need to talk to your doctor. So bloating, pelvic or abdominal pain, urinary symptoms, difficulty eating or feeling full quickly, you need to seek care. And a lot of women mistakenly think that the pap smear serves as a screening tool for other cancers. It only screens for cervical cancer. We do not have a screening test for ovarian cancer. The next cancer we'll talk about is endometrial cancer. So endometrial cancer is the most common type of uterine cancer that we treat. Endometrial cancer starts from the lining of the inside of the uterus. There are other uterine cancers that can develop, such as cancers that start from the musculature of the wall of the uterus, and so those are called sarcomas. Those are far less common. What we're going to concentrate on today is the endometrial cancers. So uterine cancer is the most common gynecologic cancer that we treat, and it's the fourth most common cancer in women. And this is just a picture of what we might see. Normally when we look inside the uterus with the camera, the lining of the uterus is very smooth and homogeneous, meaning it all looks the same. Someone who has an endometrial cancer will have a growth, a tumor that is situated on the lining of the wall. So risk factors for endometrial cancer are, again, age. Unfortunately, as we get older, we have more risk of cancer. 75% of women have already gone through menopause when they're diagnosed with endometrial cancer. Other risk factors include obesity. Excess weight leads to an increased circulating level of estrogen in your body, and that estrogen can then drive the lining of the uterus to grow. So that's why obesity is a risk factor for this disease. Use of estrogen alone without a progesterone increases the risk of endometrial cancer. So we never recommend that someone who has a uterus take just estrogen. You need to take estrogen and a progesterone. Other risk factors include diabetes, hypertension. Tamoxifen, which is given for patients with breast cancer, has a risk of increasing the risk of endometrial cancer. Again, infertility or later age of menopause after the age of 52 is a risk factor for this disease. And then anyone who has a family history of uterine, ovarian, colon cancers may have increased risk for this cancer. So the most common symptom that people present with endometrial cancer is bleeding. And regardless of your age, if you have abnormal bleeding, it is a reason to see your gynecologist. In older women who have gone through menopause, any bleeding is considered abnormal. I can't tell you the number of patients that I see who come into my office with a diagnosis of endometrial cancer who have been bleeding for over a year, and they tell me, oh, I just thought it was my period again. Well, if you've gone through menopause, you should not have a period again. So any bleeding, and whether that's actual blood that you see, if it's a pink discharge, that can be a sign of endometrial cancer and needs to be checked out. Now, of course, it could be something else. It could be a benign polyp. It could be something else going on. But it is the main symptom that we see with this disease, so it deserves attention. So the typical evaluation that you're going to get if you come in with abnormal bleeding is you're going to get a pelvic exam, and usually that exam includes a rectal exam. We may do a pap smear as part of that evaluation to make sure that the cervix isn't the source of the bleeding. And then typically most patients are going to get both an ultrasound and then a sampling of the lining of the uterus. So we need to obtain a sample of tissue to know what is causing the bleeding. And that can be performed either as an office endometrial biopsy or as a DNC, which is typically done in the operating room under anesthesia. So most endometrial cancers are stage 1. 75% of these cancers are confined to the uterus at the time of diagnosis. And so when we talk about staging, when we talked about how cervical cancer is clinically staged, uterine cancers are surgically staged. And what that means is that we don't assign the stage of the cancer until we've usually done the surgery. We may do more testing before the surgery to make sure that surgery is the right treatment option for you. And those tests may include doing imaging, including a CT scan of the abdomen and pelvis or a chest x-ray. Surgical staging typically involves performing a hysterectomy. The hysterectomy means removing the uterus. We also typically remove the tubes and ovaries. Again, that depends on the patient's age of diagnosis and If they're young, sometimes we do preserve the ovaries. And then most commonly, we do a sampling of the lymph nodes. This cancer tends to spread to the lymph nodes, and so that's part of the staging procedure. And the types of hysterectomy that could be performed, we could do a hysterectomy through an open incision. Sometimes that's necessary if someone's uterus is very large or there's other factors that might prevent us from doing a minimally invasive surgery. Vaginal hysterectomies are not commonly performed for this disease process, and the reason for that is that we usually want to sample the lymph nodes, and we cannot sample them when we do a vaginal procedure. So the standard of care today is to do a minimally invasive hysterectomy, which means a laparoscopic procedure, and most commonly that's done with robotic surgery. So this is a picture of the Da Vinci robot. If you can imagine the patient lying here on the table, what we typically do is we start by making some small incisions in the abdominal wall, and we put trocars through those incisions. Trocars are little hollow tubes. And then once we have those trocars in, we can attach these robotic arms to the trocars, and then we insert instruments and the camera through those little holes. And then the surgeon goes and sits at a console. So we don't stand beside you, we go and we sit at this console, and we use little finger controls, which will then move those instruments. And so it is a great procedure. The device is very precise. Those instruments move just like my wrists do, and the imaging is very magnified. So I can see tiny little blood vessels that I can't see with any other means of doing surgery. So this is the most common way that we treat endometrial cancer now. And most patients actually end up going home the same day of surgery now. It's become an outpatient procedure. So once we've done that surgery where we've taken out the uterus, we've sampled the lymph nodes, all of that is submitted to the pathologist, and then we get a final report back. And from that report is when we assign the stage of the cancer. And so stage 1 means that it's confined to the uterus. Stage 2 means that it has grown down into the cervix. Stage 3 means that it either has spread to the lymph nodes or it has spread to the other pelvic structures, like the adnexa or the vagina. And stage 4 means that it has, again, potentially spread distantly, or it can spread to the bladder or the rectum. So depending on that report, we may recommend adjuvant treatment, which means treatment after the surgery, and most commonly that would be radiation. So radiation can be used after surgery to treat any other sites of disease that we may have identified during the procedure. It can be used before surgery. That's called neoadjuvant radiation, and that is typically done if someone's cancer is initially too large that we can't remove it surgically. We can sometimes shrink it with the radiation and get them to a point where we can then do the surgery laparoscopically. And sometimes we use radiation as the primary treatment, and that typically only happens if someone is felt to be a poor medical candidate for surgery, like they have other diseases such as severe heart disease or lung disease that would make them at high risk for undergoing anesthesia. And again, there's different types of radiation. Sometimes we radiate upper pelvis with external radiation. Sometimes we give radiation that's in the vagina, which is called brachytherapy. And in some patients who have distant disease, they might require chemotherapy or chemotherapy in combination with immunotherapy. So the common drugs that we use for this cancer are drugs like carboplatin, paclitaxel. The common immunotherapy drugs that you may have heard of are pembrolizumab or Keytruda, or dostarlimab is another common one. So again, that's typically only used in patients who have advanced disease. And then once someone is done with their treatment, they go on to a surveillance strategy where they are seen periodically to monitor for any evidence of recurrence. And so the surveillance typically involves coming in for pelvic exams, both vaginal and rectal. We may perform periodic imaging as part of the surveillance, and some cancers we perform tumor markers as well. So again, this is the most common gynecologic cancer that we treat. 85% of women survive, so that's the good thing about this cancer. If you're going to pick a cancer, this is the one to pick. And that's typically because it's diagnosed early, and that usually happens because patients start to bleed and they come in because of that bleeding. Again, it typically occurs around the time of menopause or after, and so 90% of women diagnosed with this cancer say that they experienced abnormal bleeding prior to their diagnosis. So if you have bleeding, get it checked out. Other ways you can reduce your risk is by managing your weight, like we talked about. Adipose tissue in your body leads to increased levels of circulating estrogen. So by reducing your weight, you can reduce those unopposed estrogen levels. Getting regular exercise and controlling your blood pressure and your blood sugars are other ways to reduce your risk. Vulvar cancers. So vulvar cancers are cancers that originate from the labia. So the lips on the outside of the vagina are a common place that we see vulvar cancers. They can also originate from the periclitoral tissues or from the perineum, which is the tissue that intervenes between the vagina and the anus. And these cancers, when they occur, the most common thing that they do is they can spread to the lymph nodes and the groins, or they can spread to other structures that are close to it. Vulvar cancer is a fairly rare cancer. It usually occurs in older women, usually in their 70s, 80s, and 90s. And so anytime someone has been told they don't need pap smears anymore, but they develop symptoms of itching, burning, anything that doesn't seem abnormal on the vulva, you need to go and request an exam. So this cancer, again, can be associated with the HPV virus. Not all vulvar cancers are associated with the virus. Some can be associated with other conditions that cause chronic irritation or inflammation. So lichen sclerosis is one of those conditions. If you've been diagnosed with lichen sclerosis, you have an increased risk of developing vulvar cancers. So those are, again, kind of risk factors that you want to be aware of, which may change the recommendations for whether you have pelvic exams after the age of 65. So symptoms of vulvar cancer, the most common thing that we see is itching, chronic itching. And so often this can be confused with patients just think they have a yeast infection, which may be the case. But if you treat yourself for a yeast infection and it doesn't go away, it keeps coming back, it's a reason to go get checked out. Skin that looks different than usual. So some vulvar cancers will have a different color, or they can be just different shades of your skin. We may see a bump or a lump. It can look like a wart. Or it can be ulcerated, it can be raw. Patients may complain of pain or burning when they urinate, especially if they have like an ulceration from the cancer. The urine touching that ulceration will be very painful. Bleeding and discharge, again, could be symptoms that typically are symptoms of more advanced disease, but it can be a symptom of this. Open sores or ulcers, and then cauliflower-like growths. So vulvar cancers are, again, staged usually surgically. It depends on how advanced the disease is, but most patients with vulvar cancers get surgery. And so stage 1 typically refers to cancers that are confined to the vulva. Stage 2 means that it has spread to the adjacent structure. So sometimes we see the cancer spread to involve the urethra. It can spread into the vagina, and it can also sometimes spread down to the anus. Stage 3 means that it has spread from the vulva to the lymph nodes and the groin. And then stage 4 is, again, distant spread. So typical surgeries that we do for this disease would be to remove the lesion. Sometimes with very small vulvar cancers, we can do just a simple partial vulvectomy, which is where we just remove a small portion of the vulva. Sometimes we do a bigger resection or a radical vulvectomy. That typically means removing the lesion and at least a 2 centimeter margin of normal tissue around it. Depending on where that cancer is located, sometimes we may have to do some reconstructive surgery where we rotate in flaps to close the defect. And so some of these surgeries are actually quite extensive. And then we typically remove lymph nodes as part of the evaluation to see if the cancer has spread. The most common thing that we do is what are called sentinel lymph node biopsies. So we inject the cancer with different dyes that can then travel to the lymph nodes and then allow us to find what are called the sentinel lymph nodes, or the lymph nodes that receive the direct drainage. And if those sentinel lymph nodes are positive, then we may have to go on and do a full lymph node dissection, where we remove most of the lymph nodes in the groins. Other treatment modalities that can be used for this cancer include different forms, again, of radiation, which often is combined with chemotherapy. The most common chemotherapy would be cisplatin. And some patients, again, if their disease is more advanced, might not be candidates to have surgery initially. They might be treated with chemotherapy and radiation to reduce the disease before surgery is performed. So again, because a majority of these cancers are related to the HPV infection, knowing your HPV status, having your regular pap smears performed can help in predicting this disease. Patients who have had the vaccination can reduce their risk of developing this cancer. Having an examination of the vulva is key to diagnosing the disease. And so most patients who have precancer of the vulva have no symptoms. So I encourage you all, I know it's not easy, but take a mirror and look at your vulva and get to know what it looks like. And if you notice changes that you didn't see before, it's a reason to go in and have an exam. And then changes that are appreciated need to be biopsied to make the diagnosis. So again, don't ignore your symptoms. Vulvar cancers are often confused with yeast infections. It's very uncommon, but it can be cured, especially if it's caught early. And then vaginal cancer. Vaginal cancer is cancer that develops in this muscular tube that connects the outside of the vulva to the uterus and cervix. Vaginal cancers typically start from the lining of the vagina, which that lining typically consists of squamous cells. So most vaginal cancers are, again, squamous cell carcinomas. Some cancers can be adenocarcinomas, but it's more common to be diagnosed with a squamous cell carcinoma. It's usually diagnosed in older women. Again, maybe HPV related. And so women who have a history of HPV-related disease or cervical cancers in the past are at higher risk of developing vaginal cancers. So symptoms of vaginal cancer include abdominal bleeding, bleeding with intercourse, pain in the vagina or pain in other areas that are close to it, a watery discharge. That discharge can sometimes be clear, it can sometimes be brown or bloody, feeling a lump or a mass in the vagina, and then having problems with urination or bowel movements. Vaginal cancer is usually clinically staged, so most vaginal cancers are treated with chemotherapy and radiation. Surgery is only used for this cancer when it's very small and it's very early because of the proximity of the vagina to other structures. The bladder is very close to it, the rectum is very close to it, so it is not common for us to do surgery of these cancers unless they're small. But stage 1 cancer refers to cancer that is confined just to the inner lining of the vagina. Stage 2 means that it has started to spread to the structures around the vagina, but not to the other organs yet. Stage 3 means that it has spread to the local lymph nodes. And then stage 4 is divided into 4A, which is where it has spread to the rectum or the bladder, or 4B, where there is distant spread. So again, most of these are squamous cell carcinomas and usually affect women between the ages of 50 and 70. It is one of the rarest gynecologic cancers that we treat. Often when we diagnose someone that has cancer in the vagina, it may have originated from the uterus or from the vulva. So to be called a vaginal cancer, we have to make sure there isn't cancer in one of those other organs. And again, because vaginal cancers can be associated with the HPV virus, it often can be prevented by getting vaccination for HPV. There are other types of vaginal cancers besides squamous cell carcinomas. I refer to the adenocarcinomas that can develop, but we can also see other things like sarcomas and melanomas. Most people think of melanoma as being something that's related to sun exposure. I don't think most of you are getting sun in your vagina, but we can see vaginal melanomas and they're not sun exposure related. So those are less common and are typically treated differently than the typical squamous cell carcinoma. Surgery again is used just to remove small lesions. Can bigger surgeries be performed? They can, but it's not something that we commonly do up front. We may do a partial vaginectomy or what's called a radical vaginectomy, where we're taking the perimetrium, which is the tissue adjacent to the vagina, if we think that is technically feasible. But if it is too close to the bladder or the rectum, those patients usually get treated with chemotherapy and radiation first. If their cancer recurred after having radiation, then they might be a candidate for something that's called a pelvic exoneration, which is a very expensive surgery where we remove all of the pelvic organs, meaning that we take out the vagina, the cervix and uterus if they're still there, the bladder, and the rectum. And the patient ends up with both a colostomy and a urostomy as a result of that surgery. So that's a very uncommon thing to be done. Most of the time it's either just surgery or radiation to treat the cancer. Radiation again there can be different forms. It can be external, it can be internal. And again, because of the fact that these cancers tend to be HPV related, they can be prevented. And so by getting pap smears, you can diagnose pre-cancer before it becomes cancer. By getting vaccinated, you can reduce your risk of even developing pre-cancer. So getting regular pap tests and HPV testing can reduce your risk. So symptoms again to remember: abnormal vaginal bleeding, pain, problems with urination or bowel movements, watery vaginal discharge, or a mass in the vagina. So the take home: be your own advocate. Listen to your body. Something doesn't seem right, go see your doctor. Insist on having a pelvic exam if one isn't performed. Again, seeking care early can change your outcome. And getting care, if you've been diagnosed with a gynecologic cancer, getting care with a gynecologic oncologist will also improve your outcome. Gynecologic oncologists are a subspecialization of obstetrics and gynecology. And so they've gone on after an obstetric and gynecology residency to have an additional 3 to 4 years of training in just treating these cancers. So you want to be treated by someone who knows how to treat these cancers. And here's me. This is getting ready to use one of the TMC's robots. And this is my 18-year-old son who's just graduated, going to college, and thinking about becoming the next Dr. Lewis. And that's all I have for you.
So thank you so much, Dr. Lewis. I have a couple of questions that came in that I wanted to ask. One of the questions was regarding HPV. So when you said that there was an active infection, does that mean that there are warts present?
Not necessarily. And so there are hundreds of different HPV viruses. Some of them are considered to be low risk, some of them are considered to be high risk. Low risk HPV strains are more likely to cause external warts or condylomas on the outside of the vulva. The high-risk strains are the ones that are more likely to go on and cause cancer. And you can have an active infection where the virus is replicating and have no visible warts.
Okay. The other question that I had that was related to was regarding fallopian tubes. Does removal of your fallopian tubes decrease your risk of ovarian cancer?
Yes. So what we know now is that a lot of what we used to think was ovarian cancer may actually originate in the fallopian tube. And so that is one way to reduce risk, especially if someone has a high risk based on their family history of developing ovarian cancer. One way to reduce risk is by removing the tubes. So yes.
Okay. What is normal menstrual bleeding? I know you were talking sort of like about menstrual cycles and menstrual bleeding. So what would be considered normal?
Well, for most women, they have periods that occur on a regular basis. Every woman is different as far as how often that occurs. You know, some women, they may have their cycles every 21 days. Some women may have them every 32 days. But what each woman needs to recognize is their pattern. And so a typical cycle is usually going to last 3 to 5 days and will not be associated with any bleeding in between.
Okay. Great. Another question that came in was, does your risk decrease as you get further from your family history? An example, a grandparent versus a great-grandparent versus a parent who may have had one of these cancers.
Yes, risk is higher when you have a first-degree relative who has a similar cancer. So if you only have one distant relative who's had that cancer, your risk probably is not substantially increased over the general population.
Okay. And another question that came in was, are preventative MRIs effective for detection of ovarian cancer?
So it's not something that we recommend. Unfortunately, we don't have a screening test that we think is effective for diagnosing ovarian cancer. Patients who are at high risk might undergo certain screening procedures, such as having a pelvic ultrasound and a tumor marker performed on a periodic basis. MRIs might be able to detect cancers earlier, but unfortunately, because of the cost and because of the possibility of overdiagnosing, of making patients undergo surgeries which weren't necessary because of findings that are not cancer related, we don't typically recommend MRIs.
Okay. And would, if you carried maybe a genetic marker such as like the BRCA gene, I know you mentioned that being one genetic factor, right, that increases your risk. What is best then for somebody to do in a situation like that?
Well, the best thing first is to see a genetic counselor who would talk about all of your risks. And then management depends on where the patient is in their life. So the typical recommendation for a BRCA1 mutation is to have your tubes and ovaries removed either after the age of 35 or after being done with childbearing. For the BRCA2 mutation, those cancers tend to develop a little bit later, so it's typically recommended to have the tubes and ovaries removed after the age of 40 or after childbearing. If someone chooses not to do those, do that as their option, then the other recommendation is to have periodic screening. So then we do the pelvic ultrasound and the C8-125 level typically every 6 months in those patients.
Okay. Just one last follow-up regarding the menstrual bleeding. Would no cycle in bleeding be abnormal?
Yes. So typically, now again, every patient is different, but typically not having a menstrual cycle, if it's not being caused because you have an IUD in place and it's just happening, usually means that you are anovulatory. You're not ovulating on a regular basis. And the main problem with anovulation is that it typically leads to a buildup of the endometrial lining. So the biggest risk factor for someone who doesn't ovulate is that they can then develop endometrial cancer.
Okay. If somebody wanted to see you, this is really my last question. If somebody wanted to see you, they do require a referral, correct, to come to see you. I want to go ahead and put your phone number up. It is for the TMC Health Cancer Center to see you or one of your associates. It's 520-420-2560. So please feel free to give a call if you are interested or need some, follow up for one of these gynecologic cancers. I want to thank you so much for being here today. I'm going to wrap up with our online audience and I'll turn it over to you for in person. Thanks again, Dr. Lewis.
Yes.
Thanks again for being here. We look forward to seeing you again. We are going to be going on a little bit of a hiatus for the summer, and we'll resume our online presentations in September. But please feel free. We still have classes that are going on and support groups and other activities that are happening over here at TMC for seniors. So if you do not have our calendar and you are looking for that information, please give us a call in the office. The phone number is 520-324-1960. We hope you have a great summer. Thank you.